ऑन हो गया माइक आपका। माइक ऑन है। ये माइक ऑन है। इससे आपका माइक ऑन है, ये म्यूट कर सकते हो, ये स्टॉप वीडियो कर सकते हो। अभी लोग आया नहीं है, अभी बोला आवाज तो आया है। अब रेडी है, तुम आओ। अभी तो डॉक्टर बोलेगा ही। हाँ, अच्छा दिख रहा है। दिखेगा।
প্রাণেশপুর কায়স্থ বিনয় শ্যাম চৌধুরী। पांडे को मित्र रखो।
वहाँ रिकॉर्डिंग चल रहा है।
ये पूछ कौन पूछ खाना
हाँ हाँ, बोलो मत।
Good afternoon.
डॉक्टर
I'm
विष्णु
Dr. Vishnu Prasad, Professor and Head, Department of Surgery. And today's invited lecture will be by Dr. Arunkumar Karthikayan, who has joined just now. And there is one more neurosurgeon also has joined, Dr. Samudada from the northeastern region. So probably will be interacting with Arunkumar at the end of this lecture. So I see some new faces also. I'm unable to recognize. So those who would like to introduce themselves can introduce. So before we start the talk, so anybody would like to introduce yourself, please go ahead. So we will be starting the talk in another 2 minutes. So Dr. Arunkumar Karthikayan was our alumnus. And after that, he did his MCH neurosurgery, and then he's working at Kaveri Hospital, Chennai. He has done fellowship in advanced neurosurgery also. So, where you did your fellowship, Dr. Arun? Can you tell us something about yourself? You are not, can you please unmute yourself? You are muted. Can you unmute yourself?
Yes, sir. Good afternoon, everyone, and sorry for thanks for taking your time in on a Sunday for a small gathering. And I did my MBBS and MS General Surgery from the prestigious DIPMER, and I'm very proud to say Vishnu sir was my teacher and my inspiration in many ways. And we used to feel bad when he used to ride us so hard, and his tenacity and his responsibility towards patients. And as residents, we regretted those things. But now I realize those are the qualities that make a very good surgeon. And after completing my MS General Surgery, I was practicing laparoscopy. Then I went into neurosurgery and did my MCH neurosurgery from Sri Chitri Tirunal, Trivandrum. Is one of the top 3 or 4 institutes for neurosurgery, and on par with AIMS, NIMANS, and SCPJ. So I had a very good exposure in neuro-oncology and in advanced endoscopic skull base. And advanced endoscopic skull base, because we didn't have the luxury of ENT surgeons when I was training there. And, so we used to do the whole exposure and whole reconstruction by ourselves, including transsphenoidal and clival transteroid approaches. And so we had a very good neurology team which supported us for high load of deep vein stimulation surgeries and epilepsy surgery and endovascular surgery, endovascular and vascular neurosurgery as well. And I was working in Apollo with Dr. Upesh for 3 years. And now I'm working in Kaveri Hospital for the last 2 years.
Yeah. So I think it is time you can go ahead with your lecture.
Sure,
So
sir.
now we are yeah, I think you can go ahead with your lecture. At the end, we will have some question and answer session. Initially, question will be asked by Dr. Samudadar. So after that, other residents will ask the questions.
I think Samudra will ask some question definitely. And sorry for this room, this duty room actually. And I had a surgery until late night, 2 o'clock, and I not gone back home. So I didn't want to cancel this meeting. So we'll go ahead. And I'll share my screen. Just a moment, sir. Can you see my screen, sir?
Yeah, we can see your screen.
So one thing, so this talk is not going to be very, very technical. I just want to make it a little more exciting so that surgeons, even MBBS students, will have some liking or interest towards neurosurgery. And the topic which I promised Vishnu sir is endoscopic skull base, expanding the horizon, and that is more advanced endoscopic skull base approaches. But due to some recent events, I'm going to embark on some other topics as well. It is because as many of you would have realized, the recent NEET PG results have come. And you can see that neurosurgeon, general surgery students are not very much interested in taking neurosurgery nowadays because they find it little strange, difficult, or poor results, and many other reasons for that. So I'll be touching a little bit on how neurosurgery is going to be in the near future as well. And yeah, so this is me. I don't look when I don't shave and when I don't comb my hair, I look like this. When I do all that, I look little smart. So I'm Dr. Arunkumar Karthikayan, and coming to endoscopic skull base. For that, we need to know a little bit about the history of neurosurgery. So Dr. Harvey Cushing, whom we call as the father of neurosurgery, proved to the world that neurosurgery is possible, and the mortality rate could be drastically reduced. So before Dr. Harvey Cushing, the mortality was around 40 to 70%. So they're so afraid to open the brain. People are so afraid to open the brain or do any surgery on the brain. Whereas Dr. Harvey Cushing single-handedly changed the whole scenario. He decreased the mortality rate to less than 10%, which is not a simple feat, considering he operated in an era where there was no operating microscopes and there was no neuronavigation. There was hemostasis was at a very primitive stage, and even anesthesia and awake craniotomy, intraoperative neuromonitoring, all these facilities which we have at our disposal very easily nowadays. Without any of this, he was able to do an excellent surgery. So he is undoubtedly the father of neurosurgery. So, and now even with all this equipment which I have been telling you, in neurosurgery, the safety margin is very less. The difference between very good surgery and a very bad surgery is very, very less in neurosurgery. So that's the reason for the rigorous training, and most of the neurosurgery residents drop out of training, and it's not very popular among surgeons. It's because of all that. And coming to the recent advances, we had operating microscopes, which give us excellent visualization of in the range of 30 to 40 times magnification, so that only the tumor. It's like neurosurgery is something like robbing a bank. You get in without creating any mess. Just take what you want and get out. So if there is a tumor, you customize the treatment according to each patient, whether it can be done approach endoscopically or through a small craniotomy, keyhole craniotomy, supraorbital craniotomy, whatever it is. But you need to sit with the scan. You need to form a customized plan for each patient, and with as minimal damage as possible, you need to get out get the stuff done. So we have very good operating microscopes, which are huge and which are the beloved parts for surgical armamentarium. It is we have advanced microscopes on par with what is available in the US, and weighing around 500 kgs, and they give us unparalleled vision of what you are doing. And with microscopes, we even have can delineate the tumor. We can do intraoperative fluorescence. We can give indocyanine green, which can see the blood vessels separately, so that only what is needed is taken out with as minimal damage as possible to the normal brain parenchyma. So in the 1960s, we started having the microscopes coming in, and that changed the whole neuro gamut of neuroanatomy and neurosurgery, microneurosurgery as a whole. And only the last 2 to 3 decades, we have been seeing more of endoscopic skull base. But if you see our gastrosurgical counterparts, laparoscopic surgery has been quite a while, even before endoscopic skull base came into vogue. It is because of a major problem of repair. And so when if you can see in this picture, it is through the nose, endoscopic skull base. most commonly is done through the nose. So basic endoscopic skull base is with the endoscopic camera and with two surgeons and 4-hand technique. This is the sphenoid sinus, and orbit is on either side. This is the skull base, anterior skull base. You can see the pituitary, sella turcica, and pituitary gland, pituitary stalk, optic chiasm, and you can see the midbrain and pons here. So transtubercular approaches and transtubercular and transphenoidal approaches and transclavial approaches. So the basic endoscopic skull base will be this. What I'm seeing here, through the sphenoid sinus, we can approach this whole region. So that's how it started. And initially, when neurosurgeons tried it, they found it a little difficult. And then they started doing through the transseptal microscopic approaches. They started using the microscope and they started using the microscope to go into the skull base. But the advantages of an endoscope over microscope is huge, which you can understand because with an endoscope, you can actually take the endoscope to the point where we need to do the surgery. So it's a dynamic movement, unlike a microscope. And I have my dear ENT colleague who we work in tandem with each other. And when he exposes, I assist. And when I start doing the intradural work, and he assists. So that sort of collaboration gives endoscopic skull-base surgery a great edge. So only with collaboration, we are able to go into difficult regions. So into transbrachal, transplanum, cribriform, and transpterygoid approaches, which are very, very difficult. So coming to the primary thing which I was telling, the initial difficulty in endoscopic skull-base surgery used to be the CSF leak. So after any endoscopic skull-base surgery in the maybe 2 decades before, 1 or 2 decades before, the rate of CSF leak used to be very high. So that is a disaster when CSF leaks and patient gets meningitis, and it is many times it is fatal. Patient will die, we'll lose a patient. So when we started getting more techniques or more anatomy and more techniques of repair, so we were able to circumvent this challenge. So nowadays, even with a large defect, we can remove large tumors from here to here, even large drilling. We can go until the lower brainstem. Everything is possible because we have very advanced techniques of repair, which is made possible by a collaboration between teams. So that is a message I want to give. So if for MBBS students, if I can explain this picture, this is not going to be a very strong neurosurgical topic because we have a mixed audience here. So I'll be touching on little basic aspects as well. So this is a frontal sinus. You can see this is anterior, this is posterior. You can see the nose here. It is a lip. This is a hard palate. This is a soft palate, and this is a lower lip, and this is a tongue. So basically, when we go inside with an endoscope, we try to lateralize the turbinates. So we have turbinates inside our nose on both sides. So superior, middle, and inferior turbinates. So that needs to be lateralized, and so that our instruments can go inside. So that is the first basic point. And sometimes when the space is too less and we're going to plan little advanced approach, we try to take out the middle turbinate on one side. So that will give us more room to expand and work with both hands. So when we come to binostril approaches, we need to do a posterior septectomy. So the septum in the middle, the posteriormost part of the septum will be taken out so that surgeons can operate with 4 hands. So one hand on the ENT or neurosurgeon can hold the endoscope, and rest we have 3 hands, so that it becomes very useful in that manner. So we do a posterior septectomy, and then we go into the sphenoid sinus. So I'll be showing all this in my surgical video. So I'm just running it through so that it doesn't become very overwhelming for people who are not used to neurosurgery. So once we see the sphenoid sinus, we can see the sphenoid ostia staring at us. It's we call it the owl's eye appearance. So once we see the sphenoid, then we do the sphenoidostomy. We open the sphenoid widely, and go down until the clival recess and remove the sphenoid mucosa. Then we look at the cellular flow. So once we are in the cellular flow, we will have internal carotid arteries on both sides and optic nerve coming from both orbits and converging together, forming the optic chiasm. So in below the optic chiasm and in between the carotids, we will find a small cellular region, which is like only this. It's very, very small. It is now 1 to 1.5 centimeters. That is a whole working area. But with the use of an endoscope, it is highly magnified, and we have very instruments which can help us. So this is a picture which I was telling. And yeah, so these are the posterior ethmoid cells. You can see the large cells. These are posterior ethmoids which need to be opened on both sides, so that we go until the lamina papyracea on both sides. So that will give us a very expanded corridor to work very easily. And this beautiful structure, what we see here is an optic nerve on both sides. You can see the optic nerve converging medially, coming together and forming the optic chiasm somewhere here. So below that, this is cellular flow. So which is being drilled with a 1 millimeter diamond drill. So you can see the level of magnification is possible here, which is not the way with a microscope. Microscopes have their own advantage, but endoscopes are the future. So if you can concentrate here, this structure is an internal carotid artery, paracellular ICA on both sides. You can see the optico-carotid recess, the medial OCR and the lateral OCR. So optic nerve and the carotid artery, they make an angle here. Okay, so we will get the cavernous sinus around this region where I'm tracing on both sides. So the cellular, the region of interest will be around here. So whenever a tumor is going laterally into the cavernous sinus, previously it was considered difficult to operate or even inoperable. Nowadays, we are able to strip out very difficult tumors from the whole carotid without causing any carotid injury and taking it out. So that is very well possible. And we can control the cavernous sinus bleed also with all the hemostatic agents. If I can go back a little bit, neurosurgery is operating with blood. So we have a bloody field or the tumors bleed. So hemostasis is of utmost importance in neurosurgery. It's interestingly, if you take the history of surgery, it was the monopolar cautery, which is even now it is called Bovie in the United States. It was first used by Dr. Harvey Cushing. So when he started using Bovie, then he called back all his previous patients so that which tumors he wasn't able to operate because of the horrible bleeding. So he called them back and he reoperated on all those difficult cases. So that's how important hemostasis is in neurosurgery. So cavernous sinus bleed can be catastrophic. You can lose liters of blood very fast, and it can become highly disorienting. And we have all the cranial nerves going through the cavernous sinus, and IC injury can occur. So both the operating surgeon and the assisting surgeon, as well as the whole team, they need to be aware on what can go wrong. So this anatomy picture is from Broadening dissection. So this is more clear for the surgery students or MBA students, if at all they are part of this meeting. You see the ICA on both sides. So this is the internal carotid artery, and it is forming the carotid siphon. You can see the carotid siphon here, which is coming forward and looping back. So this is a beautiful carotid siphon, and you can see the pituitary gland here. And what I was showing in the surgical picture is optic nerves coming medially and joining to form the optic chiasm. This is the optic chiasm. So whenever pituitary tumor enlarges, it enlarges and presses on this optic nerve or optic chiasm, causing visual problems. So that's how most of the pituitary patients present with, and some patients present with compression of stalk and compression of the normal pituitary gland, causing hormonal effects. So that is yet another way they present. So we have functioning pituitary adenomas and non-functioning pituitary adenomas. Functioning pituitary adenomas, if it's secreting prolactin, if there is high level of prolactin, we give cabergoline, earlier bromocriptine, so that the tumor shrinks and becomes small. And sometimes it's even curative, even though long duration of treatment might be necessary. But if even in prolactinoma, if it is becoming refractory to medical management, we can always go in and remove the tumor. So sometimes we need to look at the anatomy. We call kissing carotids, where both the carotids are very close by, and it is difficult to approach endonasally. Yeah, this is from the looking from above, looking at the skull base from above. You can see the anterior cranial fossa until here, the sphenoid reach here, and the tuberculum sella. This is a cavernous sinus region, and this is a middle cranial fossa. This is a middle cranial fossa where we have the temporal lobe on both sides, and this is a clivus, and this structure is a foramen magnum, where brainstem continues down as a spinal cord. And this is a petrous ridge. You can see the petrous ridge on both sides, and this is the posterior fossa. Okay, so all these colored structures can be accessed through advanced endoscopic skull base approaches. Yeah, in the cribriform approaches, TC, and transplanar approaches, and transphenodal approaches, which are the most common, and transpterygoid, and even until the foramen magnum is possible. So this is a brainstem. You can see the midbrain. You can see the basilar artery. You can see the third nerve, oculomotor nerve, coming in the front from the intercrural systems, and this is a cavernous sinus on both sides. Cavernous sinus, and this is a pituitary stalk, which will go and get attached to the optic chiasm. So optic chiasm is not seen here. Optic nerves are cut and retracted, so you can see the pituitary stalk. Okay. So I will show you an intraoperative picture of this beautiful pituitary stalk in a patient. And in that patient, the tumor was very hard and firm. So we were not able to visualize the normal pituitary gland or the pituitary stalk. And in firm tumors, it's always very difficult. So we had to give a lot of traction, and patient had a lot of sodium electrolyte issues post-operatively, but she recovered well. So this is a pituitary stalk. You can visualize this from above, what we're seeing from above. The same pituitary stalk we are seeing endonasally, transphenodally in this picture. This is from a live surgery. So this is optic chiasm, and this is a pituitary stalk. You can see the longitudinal striations, and this is a normal pituitary gland. And we were able to identify this as a normal pituitary gland only after we got to see the stalk. And this is optic chiasm. You can see the hypophyseal arteries as well. This is a very high magnified image that is possible only because of the endoscope. With an microscope, to reach here through a transcranial approach, it is very difficult. So we need to come through laterally and cross the opticocarotid systems and reach. So that is how it was being done earlier. It is all made simple because of just because of the advances in endoscopy and endonasal approaches. Okay, so I'll stop here. I'll show you a few surgeries, and so I'll change my screen sharing to just a moment. Vishnu sir, are you able to see me? Are you able to see the screen?
The same one is being shown.
Can you see the scan here? Just a moment.
I can see you.
Only me, not the screen.
Screen is not shared.
Just a moment. I'll go to the time player. There. Can you see it now?
Yeah. Now we can see.
Patient who came with this patient came with the history of pituitary apoplexy and acute deterioration of vision, bitemporal hemianopia. That's how it is. We classically describe, and even if the students they know bitemporal hemianopia, it is because the pituitary tumor presses on the optic chiasm and causes vision loss on both sides. So I will show you the tumor and the bleed also. This is a bleed. It's more clear in a coronal picture where you can see both carotids hyphen on both sides, where carotids come forward and they go back. So that's why you're seeing two here. And this is a contrast enhancing tumor. An optic chiasm is somewhere here, and this is a lateral ventricle and the third ventricle here. So this large thing is a sphenoid sinus. It's slightly extending into the cavernous ICA on both sides. You can see the pituitary stalk here, very clearly seen. So as I told, when you go endonasally, the approach is very, very important. So even though I said we didn't have the luxury of having a good ENT skull-based surgeon backup when I was back in Sri Chitra. We used to do everything by ourselves. But I understood working together as a team gives a very big advantage, so that so that the approach as well as the repair can be very perfect, and the level of stress is also very less. And when you have another surgeon who understands you and who integrates, and you go do all surgeries together, so that increases a lot of confidence. And even the recent advances in endoscopic skull base, it's because of the collaboration between the ENT surgical team and the neurosurgical team. So this is my ENT colleague, Dr. Ashwin. I'm assisting, and he's giving me the exposure. You can see the septum, and he's creating a Haddad flap. So Haddad flap is basically a vascularized pedicle flap, which is based on an important vessel and sphenopalatine artery. And so this pedicle flap will be taken at the beginning of surgery and kept below, and so that it is a huge asset when we do the repair. So before that this Haddad flap was discovered, and this type of repair was made possible, the endoscopic CSF leak, cerebrospinal fluid leak chances were so high, and the morbidity was high. I myself have seen losing patients just because of severe meningitis. Even they doesn't respond to all higher antibiotics. Whatever you do, you would have removed the tumor, but because of the CSF leak, we'll lose the patient will die. So this is very, very important. So you can see how he is elevating in the avascular plane. So beautifully, the flap is coming out. As we go posterior into the septum. So if you get the right plane, the bleeding is very minimal. If you're bleeding too much, it means you're not in the right plane. So yeah, I'll pass here. So I was telling previously, this is the outside appearance. So this is sphenoid ostia on both sides, scala former, and so this just imagine an owl with two eyes and a beak here. So that is the outside appearance. So we have just opened it, and this is a debrider he's using to remove. This can make things faster. Yeah. So we have now opened the sphenoid sinus and removed all the mucosa. You can see the intersphenoid septum here. So it is necessary to have pre-op session where both the surgeons sit together and they know clearly the intricate details of all anatomy. I'll tell you what we had missed and we found out during surgery. So this is an intersphenoid septum which is going and getting attached to the cellular floor. Sometimes this intersphenoid septum, as you see here, can go and get attached to the optic nerve as well. So when you do rough manipulation, you can damage the optic nerve. And sometimes there can be onodi cells, posterior part of the posterior ethmoid cells, which leave a bare optic nerve. So that also can get damaged. And this septum, if it is lateral, there is a high chance it can go and get attached to ICA. So I'll give the orientation now. You can see this is optic nerve, and this is optic nerve on both sides. So this is the right optic nerve and this is the left optic nerve, which are joining to form the optic chiasm. And this structure which you see here, it is the internal carotid artery on the right side. This is the internal carotid artery on the left side. If you look closely here, you can see the bone is not there. So myself and my colleague, we both missed it during the pre-op session, but intraoperatively we were surprised to see there was no bone at all. So this portion is at a high risk of injury. When you don't see this, appreciate this properly and use a drill or use a debrider, you can actually tear the internal carotid artery, which is catastrophic. So we should never, these are never events which should never occur. So internal carotid artery should never get injured. So another point is we don't use hard instruments, we use diamond drills to make it so wafer thin, then we can separate it. So I'll show you that. So here you can see the clival recess. So this is a clival recess. This is a paraclival ICA. This is a paracellular ICA. Yeah. So this is a diamond drill which we are using to take off the septum, sphenoid septum. And I'm not using any pressure at all. If you can see, not using any pressure. This is like a paintbrush. Just so this tactile feedback is very, very important so that you don't plunge into the dura. So just like a paintbrush, we just take it out. Yeah. So what I'm touching here is the internal carotid artery, which is bare, without any bony covering, bony protection. So it is highly prone for injury here. So this is optic nerve, which are seeing at such a close magnification. This is not at all possible in any microscope whatsoever. So that is the advantage of an endoscope, a good endoscope. So this is a clival recess on both sides. And this is the internal carotid artery. You can see the bony covering here. Okay. So we need to go as low as possible so that when you do the repair, what I was telling you is a Haddad flap should go and sit properly and give us a good approximation. So this I'm making the cellular floor wafer thin so that we can easily break it out. Any questions, sir? Yeah, you can see it's become wafer thin. So the cellular floor is taken out. So this we are looking at staring at the dura now. So as we go inside, you can see the inferior turbinate, middle turbinate is removed on this side, and subtectomy is done so that 4 instruments can come inside. And here. Yeah. So here, once this is paper thin, you're trying to punch out with a Kerrison sponge. This is very crucial. You can have anterior intercavernous sinus here, which can bleed horribly. Losing half a liter of blood is very easy, either in the anterior intercavernous sinus or in the cavernous sinus, and it happens very fast. Since there comes the disadvantage of an endoscope because the opening is small and the space is small. If it bleeds little bit also, you won't be able to see anything. So that is the issue. And yeah. So this patient had a little extension into the cavernous sinus as well. So I'm going laterally so that you can see the cavernous dura also. The cavernous dura, it bleeds. So the rule is never avulse anything, never pull anything, just punch it out. Just punch it, take it out. So each step has to be followed meticulously and laboriously. You can you see the bluish cavernous sinus here? This is very beautiful, bluish cavernous sinus dura, which you can see. So again, the carotid artery, which is staring at us in the face without any bony covering. The posteriormost part of the cellular floor. This is a clival recess. So I'll try to remove this bone as well. which will give us huge leverage to take out the whole tumor. So the aim of any pituitary surgery is to remove the whole tumor. There is no compromise at all. And we have major difference between a surgical oncologist and a neurosurgeon is that we violate all surgical oncological principles, because surgical oncologists will never see the tumor. We'll have a margin all around. Whereas in neurosurgery, it's always the other way around. We do internal decompression and then try to take out the tumor. So you can see the dura very well prepared here, bulging into it. This is a case of, I'll remind you, this is a case of pituitary apoplexy. In that case, the blood and degradation products will be under pressure. So that is the reason for acute visual deterioration. So when we open it, it just gushes out under pressure. So this is a semi-quasi neurosurgical emergency. Whenever pituitary apoplexy is there, we need to operate as early as possible to give a good visual outcome. Whenever optic nerve compression is crossed a certain stage, even when we do the surgery, it's not going to improve. So it's necessary to tell the patient to do. So I'm opening the dura with the 11 size blade sharply. You can see blood products coming out because the tumor is bled already into. So in this case, I used a lumbar drain to inject some saline and fluorescein into the subarachnoid space so that I can give Valsalva and push the tumor out down into the surgical field. So you can see the tumor contents. It is little friable. This is a cavernous dura. I have ordered cutting over the cavernous dura. Yeah. So now we need to separate. This is a dura. We are trying to do an extra capsular dissection. So the tumor will be variable in consistency. The soft parts which are bled and necrosed, that has come out initially. Now we need to tackle the firmer areas, which is a little more difficult. So it takes patience little by little. So we need to keep reorienting ourselves where are the critical structures, and we don't want to damage the arachnoid as well. So once we damage the arachnoid, the chance of C-sub leak is going to be very high. So never damage the arachnoid. Try to take out the tumor with the arachnoid intact completely. So anterior intercavernous sinus is around here. So I have kept an oxidized regenerated cellulose, called Surgicel here, to stop the bleeding. So initially we do the posterior parts first, so that if you do the anterior part first, the whole arachnoid will bulge up, so you won't be able to do. So I'm using microsurgical instruments. These are very small instruments which appear very large because of the endoscope and magnification. These are smaller instruments. So some part of the tumor is attached to the dura. And going to the cavernous dura now, we can, after some time, we can see the cavernous carotid artery pulsations. So this tumor should also be separated. It's attached to the cavernous dura, will be removed. This little dangerous step where if we pull the tumor, which we should not avulse the carotid artery. So once we have finished the posterior parts, we're going to the lateral part, then finally the anterior part. So this tumor is left until the last minute, so that we can be sure we have removed everything else. Yeah, this part of the tumor is firm, so I'm giving very gentle traction to separate it without avulsing any part. Until now, we are not seeing the normal pituitary. So that is also very important. We should not pull out the normal pituitary. That will cause a lot of hormonal issues and lifelong hormone supplementation for the patient. So this is the dura anteriorly. Anterior intercavernous sinus is here, and yeah. So you can see the bleeding now. once the anterior intercavernous sinus is reached. This is the remaining part of the tumor, and this part, yellowish part, what is seen, looks like normal pituitary. So there's an internal carotid artery which is pulsating on the left side. If you look closely, it is pulsating. Rest of all the tumor is removed and scraped off and removed. And this thing is anterior intercavernous sinus. So it can cause torrential bleeding. So we have special bipolar forces for that. So whenever we try to coagulate dura, because dural venous sinuses, it's like a single dural leaflet. It opens up, forms the dural venous sinuses and closes again. So when you try to coagulate it, one leaflet shrinks, causing the bleeding to increase. So when you use instruments like this, it's like welding. You have two jaws which holds it together and seals it. So this is a very important instrument, and it is used only in this part of the surgery. No other use for this. This is a very important use for that. You can see the anterior intercavernous sinus, if it bleeds, it is very difficult to control. Not by conventional means. You can see the bleeding here, brisk bleeding, and just hold it and burn it off. So this is a normal pituitary. This is a normal pituitary which is pushed to the right side. Yeah, this we have kept hemostatic agents here. I have taken facial lata and fat. So this is a multi-layered repair. We are not doing a gasket repair here. When there is high CSF leak under pressure, for example, from the third ventricle, in that case, what we do is called a gasket repair, where we take the septal bone, which we have taken from the patient, and fashion it according to the exact size and put it inside, so that it goes inside the bony edges. So whenever there is CSF pressure, it comes out and blocks the exit, so that it doesn't leak outside. In this case, there was we have done a good job. We have not opened the arachnoid, and so there is no high pressure CSF leak. So only multi-layered repair will suffice in this case. So we kept fat from the thigh and facial lata. I'm going to show the facial lata again, so that we, yeah. Sorry about that. This is a normal pituitary. This is anterior intercavernous sinus. And this is a tumor cavity where the tumor has been removed completely. And now these are all hemostatic agents. It is oxidized regenerative cellulose, and this is a fat. This is a fat, and this is a facial lata. As you can see, we remove all the mucosa all around, so that the facial lata and the Haddad flap should stick onto the repair. So this is very, very crucial. This pedicled Haddad flap, which I had taken initially, if you remember, the first step of the surgery was this flap, which is being rotated and placed. So if you ask a single most important thing which has revolutionized endoscopy skull base, is this thing, which was discovered by an ENT skull base surgeon. So there comes a need for interdepartmental collaboration. It's not about ego. It's not about money. It's about what's good for the patient. Here, once you have placed the Haddad flap, now you are placing Surgicel. These are all hemostatic agents over there, and we are pouring fibrin glue. So fibrin glue will solidify and seal this part. You can see fibrin glue, which once we, yeah, becomes solidified and hardens. So this gives us a foolproof repair where the patient will not have any CSF leak at all. So this is a post-operative scan where you can see the opening which are done. This is a frontal sinus, this is anterior, this is posterior. There's a nose, there's a hard palate, there's a clivus, there's a sphenoid sinus which is open here. There's anterocranial fossa, there's a midbrain, pons, and medulla, cerebellum. So just to show the orientation. And there's a lateral ventricle, third ventricle. You can see optic chiasm somewhere around here, and you can see the whole tumor has come out. In the complete excision. Okay, I'll show you one more video if time permits. This is another beautiful video. Yeah. Can everyone see the video? Vishnu sir, can we see the video?
No, no.
No,
It's,
just-
you have to share. Yeah, now we can see the, yeah, now we can see.
This special case, yeah, this patient came to us from Kolkata, and she had been having galactoria for past 8 years and managed by physicians, and they not taken a scan. So whenever she has galactoria, they give her cabergoline tablet like a toffee. So she takes cabergoline, no galactoria, she stops, and this same thing has been going on for last 8 years. And when she came to us, obviously we thought it is prolactinoma. Then we asked the patient and her husband to bring all the records right from the beginning, whether any one single prolactin value is high, more than 200, I would have told no surgery. So we did that. All the values are less than 50, astonishingly, but she still had galactoria. So this is called stack effect. When a tumor which is not prolactin secreting presses on the pituitary stalk, causing galactoria. So that is the case. But what happens is when we start giving cabergoline, without the proper diagnosis, pituitary tumors are usually soft. If I use two section, that's called two section technique. Usually pituitary tumors come out very softly. But when we give cabergoline, we create a monster out of the normal tumor. It becomes firm and horrible. So this case was a real challenge for us. In case myself and Dr. Ashwin, we thought we'll abandon the surgery. We don't want to risk her. It's a very young lady, and because the tumor was that hard. But we took our time and took a break. And it's from one of my mentors, Dr. Jan, he used to tell whenever there's a difficult part of the surgery, take a break, freshen, and go again. So we took 4 hours to remove this tumor, and slowly we were able to strip out the firm tumor and from the internal carotid artery. So that is highly risky because internal carotid artery rupture. Once it ruptures, you'll get blood coming out of the nose. We can't see anything. You can't put in a scope, nothing. We don't have a craniotomy. So it's going to be horrible. So, but still we're able to manage. And this is one of our very good successes. So you can see it's a T2 hypotumor, is a contrasynapsis, and it's going lateral. It's going lateral to the carotid. So that's called something called medial carotid line, mid carotid line, and the lateral. It's just mid and lateral. You can see it just crossing the mid carotid line. And little high up extension also. This is not very classical. This is optic chiasm, pressing on the optic chiasm, but she didn't have any vision deficits. Surprisingly, we thought she would have some vision deficits, but she was having hormonal symptoms. She was having galactoria, she was having fatigability and everything. So we told the patient and her attendant, you repeat 2 cabergoline values after 2 months, and if both the values are less than 50, and we'll go ahead and remove the tumor. So, and all this fatigability is because of the hormonal issues. So this is called snowman appearance, figure of 8 or snowman appearance, where due to the diaphragm, you can see the constriction of the diaphragm cella here. So this is a lateral ventricle, this is a third ventricle, this is optic chiasm, and these are ICS, this is sphenoid sinus. This is for orientation. Yeah. The brainstem coming into view now. This is a sagittal picture. You can see the ICS going through the tumor. And this is a beautiful picture where you can see the tumor coming into the sphenoid sinus. And this is a pons, this is a midbrain, this is a medulla, and you can see the whole sphenoid sinus. One good thing is we had a very nice sphenoid sinus, so we can access the whole tumor from here to here. So initially, you even thought it could be a meningioma also, but thank God it wasn't a meningioma. Meningiomas are a little difficult. We thought it might be a dural tail also, but it was not. So you can see the same picture which you are now used to. You can see the posterior ethmoids, which are opened up, large posterior ethmoid cells. You can see optic nerve on both sides converging to form the optic chiasm. And you can see the internal carotid artery on both sides. And the cellular floor being drilled nicely with a 1 millimeter diamond drill. But yeah, under high magnification. So we drill it nicely until it becomes paper thin. This is a clival recess. So the same steps again. This paper thin so that you don't have the dura. see the anterior intercavernous fibers here. This is the anterior intercavernous sinus coming into view. So in this case, the left-sided extension was more. So we need to remove all this bone so that we can remove the cavernous extension of the tumor. Maybe 5 to 8 years back, even cavernous extensions were not considered very much operable, but that is not the case now. We can very well remove the cavernous extensions without causing much morbidity. So the bony work is very, very important before we start anything. So here the dural incision is being placed. We thought it's going to be easy tumor, 1 hour job, where with 2 sections it just comes out. But we were in for a rude surprise, where it was a. I'm not showing the tumor part because it is prolonged. So now the tumor is removed. You can, if you can look closely, this is a brain pulsation. So this is separate. You can look closely at this. This is an internal carotid artery on the left side, which is pulsating. That is separate. So you'll be able to see the internal carotid artery only when the cavernous sinus is open and we have gone as lateral as possible. So this is a lateralmost extension of the tumor which was attached to the internal carotid artery, which was meticulously stripped off and removed. So without causing any ICA injury. So you can see the carotid pulsations here. This is a brain pulsation. This is a carotid pulsation. What I'm touching is the carotid. So bilateral extension was there into the cavernous sinus, left more than right. You can see the ICA. Yeah, ICA pulsating. So whenever you look at the ICA, you should look at it with some respect, because once it bleeds, you're not going to be able to see anything there. It's going to be only blood. So this is the right side carotid, and since the whole tumor was firm and hard, and we had to use sharp dissection, a lot of traction, which we don't usually do. But we wanted to remove the tumor completely, so we removed it. So I didn't realize this was the normal pituitary until I saw the pituitary stalk. So only when we saw the stalk, we realized that it is a normal pituitary, and thank God we didn't damage the normal pituitary.
Arun, we have to give some time for discussion also.
Yes, really also.
So Sambhuddha wants to
ask question. Okay, Sambhuddha, please wait 2 minutes.
Yeah.
So this is a pituitary stalk. You can see the oxalic acid here, and this is a normal pituitary gland. You can see the hypophyseal arteries as well. You can see the brain pulsations. So this is a very beautiful view for a neurosurgeon, and we're very, very happy to see that. You can see complete excision with the normal pituitary gland there. I want to show some other videos also, but I'm running out of time. So you can see the pituitary stalk and the normal pituitary gland, which we saw in the operative video. Is beautifully seen in the post-op scan as well, and there is complete excision.
Hello, Dr. Arun. I'm Dr. Sambhuddha speaking.
Sambhuddha, how are you?
I'm fine.
Thanks for
I want to ask you 2 questions. First is intraoperatively, how do you differentiate between a tumor and a normal pituitary gland?
Usually the normal pituitary gland is a little firmer, and that is only when we have the luxury of a soft tumor. But once the tumor is firm and hard like this, it becomes difficult. So
when do you plan to stop the surgery? When do you see any difference in the color?
Color might be slightly different. As we saw in the first case, it was slightly paler, slightly more yellowish than this thing. So reddish yellow color can be there, and the consistency also, it can be slightly more firmer than the pituitary tumor. And another thing is, we need to see and get prepared preoperatively also, where same way like you must be knowing in vestibular trauma, we try to imagine where the facial nerve might be there. So here also we need to have an idea where the pituitary is. So I went again and saw the scan, and the pituitary, in the first case which I showed, we were able to see the pituitary more on the right side. So we were prepared. Even the dural opening, which we have planned it so that we don't put over the pituitary gland. Whereas in the second case, retrospectively speaking, I could identify the pituitary. but intraoperatively it was a little difficult. What I was saying is right. So sometimes it's very difficult. Yeah, this is the second case. So only after seeing all variations.
And one more question. One more question. Do you use intraoperative MRI for is there any role of intraoperative MRI for pituitary tumors?
Dr. Sambudha, I feel intraoperative MRI is very, very useful for low-grade glioma. So low-grade gliomas, we need to have complete excision. So just a moment, I'll show a scan. In which case, intraoperative MRI would have been very, very important and crucial. Just a moment. Yeah. I'll show you the scan once I start the screen sharing. Just hold on with me for a moment. Okay. Can you see the scan, Sambudha? This was
yes.
Yeah. This is a 32-year-old man with grade 2. This is grade 2 astro, and you could see.
I was asking about intraoperative tumor MRI for pituitary gland, pituitary tumor.
I can't hear you, Sambudha. I can't hear you.
Yes. No, I am talking about pituitary tumor.
I'll show the
intraoperative MRI for pituitary tumors.
Just a moment. Yeah. In this case, because low-grade gliomas, even though if you know, as you must be knowing, neurologists 10 years back didn't allow send their patients to neurosurgeons to operate on low-grade gliomas. They just gave anti-epileptics and just held off. But now we know that low-grade gliomas benefit from complete excision, because once we do complete excision, the amount of tissue which is there for malignant transformation, it's going to transform anyway into grade 3, grade 4. So that is less. So the role of complete excision is crucial in low-grade gliomas, and that has been unequivocally proved. So in this case, we removed it completely, around 6 centimeters of tumor, just stopping short of the ventricle. But I didn't have the luxury of an intraoperative MRI. So what I did was I closed the patient and took him for shifted the patient for MRI on tube. So I would suggest you do the same if you have problems with in low grade.
One more question.
Just close the patient on tube. Don't extubate the patient. Take them for an MRI. And if at all, I can't hear you.
One last question. The question is,
Sambudha.
Can you hear me? One second. Can you hear me now?
Can you hear me?
Can you hear?
Can you hear me?
One second. Can you hear me? Hello, can you hear me?
I can hear you.
Oh, mine is unmuted.
I'm sure, sir, I'm not able to hear. No.
Hello.
No.
Sambudha, what is the question?
Sir, can someone
I am able to hear you. I don't know what is the problem on the
other side.
Okay.
Yeah, I can hear you now.
Can you hear me?
I can hear you.
Yeah,
okay. Some network issues are there. Okay.
Yeah.
Carry on. You carry.
It is raining heavily in Chennai.
Yeah, some network issues there. You could carry on.
Yeah.
Thank you.
So I just wanted to show non-neurosurgeons about neuro navigation, what all things we have. This is yesterday's case. Yesterday we finished at 2 o'clock in the night. This case of metastasis. Previously we considered these tumors, we send only for radiotherapy. Large tumors on both sides, right side as well as left side. But now we are able to, all neurosurgeries are done like this. Patient is clamped, and we register the MRI onto neuro navigation machines. so that all our instruments are optically and electromagnetically compatible, so that we'll be able to track like a GPS. So this is a tumor, so just slightly larger on the left side, and on the right side is a tumor. So all this is possible. Even in endoscopic skull base, we have live navigation possible now. Even the drill which I was doing can be navigable. So this is a superior sagittal sinus. This is anterior, this is posterior, this is a coronal suture, this is a sagittal suture, and this is a small craniotomy on the left side. For the same patient, a small craniotomy on the right side. So both the tumors can be taken out in a single sitting, and we have fixed it with titanium mesh plates. So I wanted to discuss something else, but we are running out of time. So we'll take questions now.
Yeah, that was a elegant lecture with beautiful videos. It was fantastic.
Thank you so much.
I think, if there are other neurosurgeons in the meeting, please come forward and ask the questions. Residents can also ask a few questions.
Sorry, sir, I'm not able to hear you, sir.
No, I'm just requesting our residents to ask some questions.
Yes, sir.
So any other question, anybody can ask.
Any residents are there? How many residents are there?
Now around 30, 33, 34 over there.
Okay. The thing is, neurosurgery is falling out of popularity. Surgical residents don't want to take neurosurgery. So we need to make it a little bit more popular.
How long a surgery takes? The duration of the one you showed just
Yesterday's case took around 8 hours, sir. 2 tumors, 4 hours on each side. So 8 to 10. So I didn't go home. So that's why I'm like this. I didn't freshen up. I'm still in the hospital only.
What is the maximum duration of a surgery?
We had advanced endoscopic skull base approaches. We sometimes go into 10 to 12 hours. But pituitary tumors, usually 3.5 hours. But sometimes this tumor which I showed you in form, it took 7 hours. 7.5 hours.
What about the prognosis of the patients following the neurosurgery?
It's good, sir. It's good. I'll tell you, when I got into surgery, I was with, I was with Jagdish sir, and unit 1 used to be very tough. And when I told I want to take neurosurgery, all my seniors discouraged me. They told neurosurgery is not going to have results. So, but when I went to Chitra, I saw the ward was like a ENT ward. It was not a surgical ward. So patients are walking. Then I thought all the patients will be moribund with hemiplegia. It is not like that. We can have very good results with the current, and that's why I wanted to show all this new technology which we have. So neurosurgery 10 years before, it's completely different from neurosurgery what we have now. And now it's going to change further. It's going to change further. It's another 5 years, we will see a revolution in neurosurgery actually. Things are coming up in a big way.
Yeah, I agree. Looking at your videos, I feel like doing a residency in
golden time to be neurosurgeon.
Any other questions? Our faculty members are also there, and then Zoom. Shanmuram is there, Dabashish, Reddy, Abhinay Reddy, and many of our faculty are also there. 3-4 faculty are there. And the majority are our residents.
See, Sudarshan is there. Sudarshan and myself, we are MBBS and MS batchmates. Now he's faculty in Japan. Sudarshan?
Can I ask one question?
Yeah, there's a question from Madam. Can you please introduce yourself? We are new to you. Please introduce before asking a question. We would like to know from where the question is coming.
Excuse me, sir. What is the reason behind the occurrence of this tumor?
Sorry?
What is the reason for the occurrence of this tumor in the brain?
Madam, that is a very, very big question, madam. The reason for each tumor is, see, all of us will have tumor cells throughout our body. Even normal persons will have. The thing is, there are multiple defense mechanisms where tumor cells are constantly cleared and killed. Even they say even fasting clears tumor cells, good immune system clears tumor cells. So to tell a non-medical person, you can say tumor cells like a pickpocket. And so police constantly come on patrol, catch the pickpockets, keep them in control. If a group of pickpockets join together, they form a mafia. So
Okay.
that becomes a threat to the government. So tumors is like a mafia. So they evade, they can't be found. They are hiding away from police. It's like that. So there's not a
But
single
suddenly
reason,
they
multiple
attack.
reasons. Huh?
But suddenly they attack. Actually, previously I was leading a normal life. Suddenly, within the 10 to 5 days, I just feel very bad. So what, it's not like a slow poison.
There are various grades. Pituitary tumors will be grade 1. We have grade 4 tumors in the brain, glioblastoma, which is very dangerous. Even now, last 20 years, we're not able to find out any medicine for glioblastoma. Even US, you go to UK, you spend 1 crore, it's going to be 1.5 years to 2 years median survival. So hope in our time, we find cure for malignant brain tumors. But pituitary tumors, when you remove completely, it has very good prognosis. So they have a normal life. We have a normal life.
It will come back again or not? This is my question.
It should not come back. It should not come back. But we'll do regular screening with MRI. Initially, first 1 or 2 years, we do every 6 months. Then after that, yearly one time we do scan.
Okay.
Yearly once.
And heavy work, we can do the normal works.
Yeah, we can do. I'll come to your consultation differently, madam. It's not because sir, sorry, but she is my patient. And since I shared it in group, she has come. One of the videos is her video actually. And I'll come in a separate video consultation, madam. I'll clear all your doubts.
Okay.
Sure. Thank you. Thank you.
Thank you, sir.
Any other questions?
Yeah, thank you very much, Arun. Are there any more questions? Any residents?
Question, I can
ask?
Sudarshan?
Can you just wait 30 seconds? And if there are no questions, we can there's a hand is raised. Please go ahead and ask. Somebody have raised hands. Is there a question?
Good afternoon.
Yeah, please go ahead.
Sir,
Please
I
go
have
ahead.
a question.
Yeah, please go
Sir,
ahead.
I want to see any images of the operative room setup. Who holds the endoscope and where do they stand and
Who is this? Can
how
you
the
switch on your
procedure?
camera? Can you switch on your camera?
Would you mind switching on your video camera?
Yes, sir.
Yeah.
Good afternoon, sir.
You introduce yourself, madam.
Sir, I am post-MCS senior resident in Odisha SCB Medical College.
Hello, madam. Nice having you here. So,
sir, I want to see if you have any images of the operative room setup, sir.
I don't have endoscopic video, but I'll show you. Yeah. So this is a tumor surgery, but endoscope, for example, I usually may take the anesthesia station completely away. So the neurosurgeon will be standing here, and this is a vertex. So the ENT skull base surgeon will be standing here and using one hand, and so it is like this.
Your screen is not visible, sir.
Just a moment. Just a moment. Sorry, I didn't have a video picture of endoscopic operation theater this thing, but you can see this is a head end. This is a foot end. So the ENT skull base surgeon will be standing at the head end, right where the head end is, and neurosurgeon will be standing here. So two people, we need to work in tandem. And anesthesia equipment is far away there. And navigation equipment, if you are using navigation, should be around the head end somewhere. And since ENT and neurosurgeon are standing here, both need to have access of the endoscopic camera. So that is very, very important. If you have a bigger camera, you have less neck pain. So both of you should need
for
to.
Transnasal approach, this is not the image for transnasal.
This is not the image for transnasal. This is just an operation.
Yes, I wanted to know for transnasal approach the ergonomics and
just a moment. I'll give it 2 minutes.
Any more questions?
See, we have a lot of people inside the theater. So most important thing is single line of vision between surgeon and assistant surgeon. So just a moment. Sure.
There's one more question, I think.
Yeah.
One more person has
We are
raised.
nearly there.
Please go ahead. There's one more question. I think somebody
sir.
has raised hand. Please go ahead and ask the
Hello.
question.
Yeah.
Gopi Krishna.
Hello, can you hear me?
Yes, sir, I can hear you, sir. Sir, hello, sir.
Hello.
Thanks for
Good afternoon, Arun. I listened to your talk with great interest. You have evoked the interest of general surgery students, I believe.
Yes, sir.
So my question was not a question. For completion's sake, can you explain to them about microadenomas and how we operate on suspected pituitary lesions, but we do not see lesions that we don't see in the MRI? Maybe you can take an example of Cushing's disease and tell them how we approach when the tumor is not seen, and role of inferior petrosus sinus sampling also.
Yes.
That will give a complete picture. Now we are dealing with the tumor, but if it's a functional tumor, and if you say how we approach them shortly as a short, then it will be very interesting for the people.
Yes, sir. As Dr. Gopi Krishnan said, he was my senior, and we used to associate a lot right from Sri Chitra, and we have worked together, and he's a very nice senior colleague. And the question is valid, but it is little bit more complex when we handle microadenums, because as I showed in both the videos, you can't then finding the normal pituitary in the pituitary stalk itself is going to be a little difficult. But microadenomas are going to be very tiny, and if you don't see them properly, and the surgery is going to fail. So, and the patient is going to be, for example, Cushing's disease is there, then the patient is not going to have any relief after surgery. So, in that case, inferior petrosal sinus sampling will give us the laterality, and even nowadays advanced imaging techniques can dynamic contrast and advanced pituitary protocols can give us exactly where the microadenoma is. Microadenoma surgery is much more difficult compared to macroadenoma surgery. And coming to the previous question, madam, can you see the OR arrangement?
Yes, sir, it is visible.
Yeah. You can see the monitor. See, this is the most important part, madam. So, because ideally you should have two monitors. You can see monitor 1 and monitor 2. So, in that case, the ENT surgeon who's standing at the vertex and holding the scope doesn't have to twist his neck here and look at this monitor. So that will cause you a lot of pain. It is going to be very really painful and stressful when you come for 5 or 8 hour surgeries. And so neurosurgeon line of vision is this, and ENT surgeon's line of vision is this. We should have two monitors, and this is a head end, this is a foot end. Scrub should stand here, and neuro navigation should be straight. So, and anesthesia should be away, completely away from the whole OR setup. Is that okay? Did I answer your question?
Yes, sir. Yes, sir. Thank you.
Any other questions, sir?
No, I don't think any more questions are there, and we are running. Already we have crossed 1:10. I think should take leave. Thank you very much, Arun. It was an excellent lecture.
Thank you, sir.
Thank you. We will take leave from the session.